It's often said that the best way to introduce greatness is through the words of someone who knows it firsthand. Before we welcome our esteemed main speaker to the stage, let me first call upon someone who will set the perfect tone for the moment. Our introducer has been a guiding force, a close observer, and an admirer of the remarkable journey of our distinguished speaker. With a wealth of insight and an unmatched ability to articulate the essence of greatness, Dr. Priscilla Rupali, head of the Department of Infectious Diseases, here. Please join me in welcoming Dr. Priscilla Rupali to introduce our main speaker, Dr. Louise Thwaites.
Okay, I wasn't expecting that. I'm so sorry. Okay, I'm kind of shocked. So it's my pleasure to introduce Dr. Louise Thwaites to you. Dr. Thwaites, I think a lot of people have already heard about your work. So just a quick introduction. So Dr. Louise Thwaites is a clinical researcher and a member of the Emerging Infections Group at the Oxford University Clinical Research Unit at Vietnam. She's also an associate professor at the Center for Tropical Medicine and Global Health at the University of Oxford. So I think you've already heard from Ramya. Her research has focused mainly on the critical ill patients in the resource-limited setting. She has a number of published randomized controlled trials in tetanus, and she recently a lot of work done on sepsis as well. So without further ado, Dr. Louise Thwaites, over to you.
Thank you so much. Oh. Thank you so much. I feel really quite overwhelmed with that warm introduction, and to be standing here in this amazing institution and giving this oration, I feel really honored. So thank you so much for inviting me, and I hope that I can make it worthwhile that you've turned up this evening to listen a little bit about tetanus. So you heard that I'm based in the Oxford University Clinical Research Unit. So I live and work in Vietnam. We are based in the Hospital for Tropical Diseases in Ho Chi Minh City, but nevertheless, Oxford. The Hospital for Tropical Diseases is a little bit smaller than CMC. We only have 800 beds, but they're all infectious disease beds. My background actually is as a critical care physician, and I came there 24 years ago to do what I thought was going to be a small project on tetanus. And here I am today, many years later, and still working on tetanus. Just to say that OCRU, as we now are, have expanded since those early days. We have a unit in the north of Vietnam in Hanoi, Nepal in Kathmandu, and also Jakarta. And it's also great that I know we have friends and collaborators here working with us as well. So yes, tetanus, is it an old scourge? Yes, I think it certainly is. I recently had the opportunity to make a TED-Ed video, which if none of you have done before, is quite an experience for a doctor, because you have to work with a very different group of people. And actually, the people who are helping to make this, the first thing they did was pull out an old story about tetanus in ancient Greece and said, can we have this in? Let's include this. This is going to make it much more exciting. And indeed, tetanus has been known for so long, and some of the first descriptions of tetanus are in ancient Indian manuscripts. But what's the situation today? How common is it? Well, the answer is we really don't know. Most of the data are collected around maternal and neonatal tetanus. Why? Because that's the focus, quite rightly, of a very important program led by WHO to reduce the incidence and what they will call eliminate neonatal tetanus. And that's through vaccination of women. And it's linked very much to collecting metrics around that vaccination program, and also about vaccinating babies with the DTP3, 3 doses of tetanus vaccine as infants. And those are the good data we have. So estimating tetanus incidence in older children and adults is really difficult. So these are data from the Global Burden of Disease Survey, and probably many of you who know about that realize there are limitations, particularly in lower resource settings. But I think the message really is you can see where the band of tetanus is. It's those pink and red and orange colors right across Asia, Africa. At the bottom here is their estimate of incidence of the age groups most affected. So neonates still more common than older children and adults. But I think it probably does vary where you are in the world and how accurate those data are. We very rarely see cases in neonates in Vietnam now, and most of our disease occurs in older children and adults. How much do we see? Well, in the intensive care unit where I work in Vietnam, we see about 350 cases a year. We used to see about 250 when I first started. So that incidence has not changed at all over time. I tried to find some data on India because I've been having lots of really interesting conversations over the last day or so and hearing about the remarkable progress that's been made in India in reducing tetanus. And I couldn't get it to change color, but the big line at the top that's gone right down is India, and the slightly petering out flat one at the bottom is Vietnam. So it's a really remarkable piece of progress in terms of reducing tetanus that's happened particularly here. And I've pulled out the figures for South Asia and Southeast Asia in terms of reducing the incidence per head of population between 1990 and 2021 there. And I guess that South Asia is very much dominated by that Indian success story. The disability rate has also reduced, the DALI rate. But I think if you can see, if you're at the bottom there, you can see that Western Europe, we still, both in Southeast Asia and South Asia, still have a way to go before we get to those kind of levels in Western Europe. In Vietnam, we were interested to see how the vaccination programs are really impacting vulnerability to tetanus in our population, because we still see cases and we still have pockets and we still see patients occasionally coming in with neonatal tetanus. And one of the resources we have now is a big serum bank where we collect serum from different parts of Vietnam, different age groups. And this is work where we looked at serum bank samples for different age groups and from different provinces. So along here, these are all different provinces in Vietnam. So we have a mixture of urban and rural provinces. And we just measured anti-tetanus antibodies in these samples. The red line here is the protective level. So if you're above that, you should be immune to tetanus. And we deliberately, if you look at the left-hand panel, we looked at the 3 different age groups which we thought would inform us most about the vaccination program success in Vietnam. So the top panel is showing under 4. So these are children who should have had their DTP3. And for over 20 years, Vietnam has published rates of 95, 96% coverage. And it's pretty encouraging. Most children, not all, are above that red line, so they're protected against tetanus. One of the metrics that is not collected are those later boosters in tetanus by people like WHO. And it'd be interesting to know if in India that's a metric that's collected later. It certainly isn't in Vietnam, and only recently has even putting those later boosters that you need for long-term immunity into the national program even occurred. And so we were particularly interested to look at the older children. These are the age 7 to 12 years should have had good immune protection as babies, but we wanted to see if they were having those booster doses. And I think you can see that those levels are definitely dropping. It doesn't look like those children have had a kind of 3 to 5 year booster as recommended, or a lot of those. The bottom panel is showing the difference between men and women. Men are in blue and women are in the red color, to see if there's an impact on the maternal and neonatal tetanus programs. So all of the individuals born in this cohort should have had childhood vaccination. They should have had their DTP3. but the women we were expecting may well have had an extra booster when they were pregnant. And I think you can see in a lot of provinces, there is a clear difference between the men and women, but not everyone. So it's also showing that's a significant number of people who are falling below that red line. And these are relatively young adults. And then finally, just on the right, we've mapped the whole age group by the different provinces. And I think you can see, again, it's quite variable, the coverage and the immunity in the population, which probably maybe represents our serum bank from those particular sites, where the samples are coming from, but probably as well the local public health authorities and their ability to vaccinate their populations. So with that in mind, we also we present this data in a slightly different way here. It looks like the older people are less protected and the younger people are beginning to be protected, particularly the women, against tetanus. So this is data showing where the patients with tetanus, so these are people who are actually coming into our hospital when they were born. So we plotted them by the year of birth on the y-axis there. And then on the x-axis, we've got the 3 cohorts. So, but essentially, I think you can probably see that the line, which is the median, hasn't changed. So the patients in 2012, the median age is being born in 1974, and that was the same in 1994. So it's quite, in some ways, it's quite encouraging. It's suggesting that the vaccination program of those younger individuals is happening. And we're just seeing the shift through of these older people who haven't been vaccinated. So are we going to end up like India and Vietnam? Well, I hope so, but I'm just putting this up as certainly for us in Vietnam, a very cautionary tale. We have to remember that tetanus isn't an easy vaccine. You do have to give multiple doses. We, like lots of lower resource setting countries, have a lot of remote communities, and making sure we can deliver that effectively to those communities is a big challenge. And of course, there is no herd immunity to tetanus. The bacteria is in the soil, and everybody needs to be vaccinated for everyone to be protected. But on the other side is the vaccination DTP3 in Vietnam, related to a public health scare in 2013, where suddenly some children died after vaccination, probably completely unrelated. But the impact on vaccination was immense with that. And we've had a similar outbreak, a measles outbreak associated with this. And so I think it's just worth remembering that we have to keep these vaccination programs running. We've got to remember the importance of vaccination to keep these diseases at bay, and hopefully for us in Vietnam to get somewhere near what you've achieved in India. Outcomes from tetanus, it's important to think about. These are data which were published in a nice paper where they examined lots of observational studies of tetanus in Africa. And they plotted them over the years, and the dashed line is the trend in mortality rates in these studies. And you can see, unfortunately, that line more or less is vertical, indicating that there was no improvement in mortality over that time. Now, the authors had read some of these studies in detail, and their conclusion was that a lot of the deaths here were due to not lack of facilities available, but lack of access to these facilities. So I've supplemented this by putting on some of the larger randomized control trials, some of which are ours and one of which was in South America, where proper intensive care facilities were available, admittedly in lower middle income countries. And the difference in mortality rates, if those facilities are available, is quite striking, and I think is showing us what is possible. So my talk is going to focus on the evolution of management, but I wanted to just bring out those 2 points really of the things that are changing. And probably this is similar in many areas of medicine, and the things we have to be aware of as we move forward. Firstly, the aging populations and the issues that might bring, particularly comorbidity. I went back and looked at some of our patients in our studies and found now about 50% are reporting comorbidity, and that's really quite a significant load. And secondly, the fact that we do have ICU facilities in many of these countries, and what can we do with these newer facilities? I'm talking in an infectious disease and Department of Medicine institution, and I know how well educated you are, but just for people who may have been sometimes since they thought about these things, I'm just putting up a little reminder of what happens in tetanus so we can understand our tetanus pathophysiology and our management. So just to remind us, there's an anaerobic bacterium, it persists in the soil as spores, it enters the body. In an anaerobic environment, it will multiply and it will produce tetanus toxin, which is an incredibly powerful neurotoxin that's taken up in the motor neurons and transported retrogradely up into the central nervous system. It crosses the synaptic cleft and it prevents release of neurotransmitter from that inhibitory interneuron. So it effectively inhibits inhibition. And as a result, that alpha motor neuron discharge is unchecked and you get muscle spasms. We think, but we're not really sure, that the similar thing happens in the autonomic nervous system, and hence you get uncontrolled autonomic outflow, causing rapid changes in heart rate and blood pressure. That's probably old news to most of you in this room. How do we deal with it? We debride the area, we make sure there are no more bacteria around, and any that we can kill with antibiotics, we will. The good news is, in this world of AMR, is there's no resistance to Clostridium tetani. We can still use metronidazole and penicillin, which is probably remarkable. So I'm not going to go on and talk about that. We try and then mop up any toxin that's circulating in the body, and I am going to talk about that, and I'm really glad some of you have been doing your homework ready for that stage. So I'll come back and talk about that. But really, the bulk of what we do is supportive care, and it's non-specific, and that's where the ICU treatment comes in. So I'm going to kick off and just talk a little bit about antitoxin and where we've moved on to. So these are two important people in the story of antitoxin, both working more than 100 years ago. So on the top left is Kitasato, who discovered tetanus toxin and antitoxin, and then below is Sherrington, who used that antitoxin to work out the pathophysiology of tetanus. When we're treating tetanus, we want to give antitoxin. We want to know where we can give it. And I said Sherrington was one of a group of early investigators who carried out some very elegant animal studies to try and understand what was going on in tetanus. The advantage of tetanus to a researcher like this is that it affects many, many animals. And Sherrington worked out that if you experimentally induce tetanus in an animal, you could give antitoxin after that, and depending on the dose you gave, you could start to save a proportion of those animals. And if you gave it intrathecally into the central nervous system, then you could give it much later and have a much better effect. And so from that, he deduced that tetanus toxin was having that effect up in the central nervous system. Park and Nichols were looking, and they worked out that if you give antitoxin intrathecally, you can reduce how much you give. You can give a much smaller proportion than you have to give if you give it intramuscularly or intravenously. But it wasn't clear-cut. There were others who found that it made no difference where you gave it, or that's how they reported it. But not surprisingly, there's been a lot of interest to see if we can do the same thing in humans. So traditionally, antitoxins given intramuscularly or even intravenously in some countries to treat tetanus. But there have been lots of studies over the years looking at whether intrathecal administration can help. And in fact, over 100 years ago, people were giving intrathecal antitoxin into soldiers and saying it had a good effect. But I think just to sum this up, wasn't very clear. A lot of these studies were done pre-ICU, pre-ventilation. Many of them were open studies, but there is one that I'm just going to pick out because one is a randomized controlled trial, and I don't know if any of you ever learned about this study. This was performed here at this institution and was a randomized double-blind study of intrathecal human antitoxin. It was quite a small study with 36 patients in, but essentially it looked like in patients with relatively mild tetanus, an intrathecal antitoxin prevented the progression of the disease. But it probably, by study standards today, isn't enough to convince us necessarily to move forward with that. The other area with very little evidence may surprise you is what type of antitoxin to give. And I'm sure probably most of you in this room think, well, that's boring because we just give human antitoxin and that's fine. But in many countries, human antitoxin is not available. In high resource setting, it's not available at the moment. And in countries like Vietnam, it's also not available. But there has been a study, a randomized control trial, but only one that was done in Haiti, of 130 neonates who were given either equine antitoxin or human antitoxin. And the result of that, shown here, absolutely no difference in outcome in those babies. Also, impressively, really, for when it was carried out, they did do long-term follow-up and they looked actively for side effects and they reported no problems long-term and no difference in side effects in those two groups. So why do we give human antitoxins so enthusiastically? Well, probably this paper, this was in the Californian Medical Journal back in 1963, and is a case series simply reporting patients who were treated with tetanus immunoglobulin versus equine or even bovine antitoxin. And they found that the human antitoxin treated group had a mortality rate of 30%, which they thought was perfectly acceptable. And on the basis of that, they recommended that human antitoxin could be given. It's just worth bringing this up. They also estimated that serum sickness and serious adverse reactions were up to 30% if they used equine antitoxin. So those were a bit of a problem for us in Vietnam because we didn't have any human antitoxin that was licensed, and is also quite expensive. We are also very interested to know is if we did give it intrathecally, whether it was worth it, whether it would have an effect and be useful in our patients. So for that reason, we did a randomized control trial. That looks really, really complicated, doesn't it? And to some extent it was, but actually it was a simple factorial trial. We had two randomizations. So firstly, patients received normal intramuscular antitoxin, but they were randomized to equine antitoxin or human antitoxin. But on top of that, they were randomized to either have intrathecal antitoxin by lumbar puncture or a sham procedure. We blinded it in that the staff who gave all of the antitoxin came from another department. The lumbar punctures or sham procedures were done behind a screen, as was the intramuscular procedure. And so the doctors looking after the patients normally in the ward were not aware of what antitoxin and what procedures had happened. Our primary endpoint was mechanical ventilation, because I'm going to show you in a little bit later that our mortality rates, thank goodness, are much lower now. And ventilation is an important endpoint for us. And again, I'll show you why. We did follow up patients for some period of time to make sure they didn't have adverse events, because we were a little bit nervous because we were giving intrathecal antitoxin. The intrathecal, I will say, is we did use human antitoxin for that. And here are our results for people who haven't read up early on. So the intrathecal arm, the difference in mechanical ventilation was not significant, but there was a trend to the intrathecal group to have a slightly lower ventilation rate. Whereas if we look at the intramuscular, the comparison of equine versus human antitoxin, there's absolutely no difference there. Our other secondary endpoints I haven't shown, but really showed very little difference, a trend towards shorter ICU stay with the intrathecal group, but overall not a big difference. But I want to show you this because I think this is very important. This is our adverse events slide. it's a little bit hard to understand. And it was also quite hard to untangle because the patients had the two interventions quite close together. So deciding whether what an AE was related to one or other intervention was difficult. So I've written underneath what there was, but essentially for patients that got human intramuscular antitoxin and had a sham procedure, if we look at these adverse events that we thought were most likely to be allergic, we had 6 of those who had either rashes, chills, itching. For the ones who had equine antitoxin and a sham procedure, we only had 3 of those type of adverse events. So probably not different statistically, but certainly not a 30% influence. And actually, it seemed a lot of those effects were related to the group who had intrathecal antitoxin. So I think our conclusions from this study really was that in our setting, giving intrathecal wasn't helpful, but certainly it was safe to continue giving equine antitoxin, which our hospital committee were absolutely thrilled with because they didn't have to start trying to import large quantities of human antitoxin. We did follow them up for long-term disability. I'm putting this slide in just to remind you that after hospitalization, often in our kind of setting in Vietnam, we don't follow patients up very well. And we find sometimes quite surprising things if we do that. But here, there was no evidence that the intrathecal injection was harmful. But what we did find is that 17% of people were not back at work after 9 months. And here is the age demographic of our population. And you can see that most of those people are probably well within the working age, and 17% not being back at work maybe is quite an important finding on its own. So moving on now to supportive care and thinking about how some of the change in demographics and the comorbidity might affect things. I'm going to just kind of focus on 2 areas, the muscle spasms and the autonomic dysfunction. I think the most important thing, if you don't know anything about tetanus and you want to institute treatment, is make sure you can get hold of mechanical ventilation and people who know how to use it, because it really does save lives. It impacts mortality tremendously. These are data from our hospital as we introduced mechanical ventilation, which is a solid line, and the mortality rates as that was introduced. And you can see how dramatically that is dropping. But when we start looking at our population now in a little bit more detail, and we look at risk factors for needing mechanical ventilation, that's essentially what we call ABLET 3 in terms of our tetanus severity score. You can see the age is coming in there, and that's older patients are more likely to need mechanical ventilation. They're not necessarily more likely to progress to more severe tetanus than ABLET 4, but it means as we start to plan our service and we know we've got these older patients coming in with tetanus, we have to be aware of these things. So mechanical ventilation saves lives, but there are also some problems with it. Again, data from our hospital where we looked at patients, just all the ICU admissions for a year. If you just focus in the blue at the number of the patients with tetanus and the orange are patients without tetanus. And you can see, hopefully, that in the MV column, the mechanically ventilation column, about half of the patients with ventilation have tetanus. But if we look how long they're ventilated for, then the tetanus wins out by a long way. So these patients are ventilated for long periods. We need, I think, median ventilation is about 18 days now. It's this, and not surprisingly, when we're ventilating patients for that long, we have other problems, particularly ventilator-associated pneumonia. And like you, in our setting, that means usually very resistant bacteria, lots of antibiotics, and a big problem generally within the ward. And this is also why we chose this as one of our outcomes for the intrathecal study. The consequences then of getting VAP, or here, as we called it, ventilator-associated respiratory infection, is not surprisingly it's hard to differentiate sometimes cause and effect. If patients are ventilated longer, yes, they're more likely to have a respiratory infection. Their mortality rates are not very different here when we look at patients with tetanus, and that's quite different often to looking at ventilator-associated infection in diseases or sepsis, those kind of things. So it probably isn't killing patients. It may be responsible or linked to slightly longer ICU stay, but it's really associated with driving up the costs. I don't know if you can see that, but it's more than double the costs of patients with ventilator respiratory infection. And when we really look into that, the below are the total costs of patients who are ventilated with tetanus in our study, in our hospital. And in blue, the medication costs are the highest component of that care for them. And most of those costs are antibiotics because we're now using expensive carbapenems in our patients. But there are other effects actually, and I want to talk a little bit more about long-term outcome and how that's also started to change our thinking. We started trying to look at what was happening to the patients with tetanus. And the first thing we started doing was trying to quantify their weakness and their muscle wasting that they were getting while they were in hospital. Because I'm sure lots of you know, particularly after COVID, that long periods in intensive care units are bad for you, and patients lose a lot of muscle, and it can be hard to get that back quickly. So we wanted to see what was happening in tetanus. So the studies, the lines here really are the top line. Ablet 1 and 2 tetanus, and patients with more severe Ablet 3 and 4. And we were measuring their rectus femoris muscle cross-sectional area, which is a good proxy for muscle wasting. And what we found really was by the time patients left ICU, they lost maybe 20 to 30% of their muscle bulk. That's a lot of muscle. Is also, interestingly, very much comparable with patients with sepsis or other severe critical illness. And when we looked for risk factors for this wasting, hospital-acquired infection came up as an independent risk factor for muscle wasting. That's backed up by some pathophysiological evidence that inflammation is part of the driver of muscle wasting. But if you link that to the amount of VAP that we're seeing, it's another reason for us trying to prevent pneumonia. It might not be killing the patients, but it is expensive, and it may be driving other problems like long-term outcome. We then looked at muscle wasting linked to their longer-term functional outcome, and we found, not surprisingly, patients with more wasting had more problems long-term. But I want to show you this, which are SF36 scores of our patients with tetanus at discharge, which is the red line, 3 months, green line, and blue line is 6 months after discharge. So SF36 is a nicely validated score that looks at different health domains, a physical side and an emotional side. For the younger patients under 70, there were some limitations still at 6 months. Ideally, 100, the kind of outer ring there is back to normal, no problems. But I think the startling difference is if you look on the other side at the over 70s, which are a significant proportion of patients we are facing coming in, how poor their functional outcome is after a period of hospitalization with tetanus. And that's a real challenge. Now, I don't think we're alone in tetanus with this being a problem. I think it is common in other critical illness. And I don't think I have the answers either, and I don't think anyone has. But this is one thing we're trying, is physical rehabilitation. Physical rehabilitation promotes muscle growth, we hope, and functional mobility. And we hope getting patients back and active sooner is going to be valuable for them and also their families. But we're in a low resource setting. We have 2 physiotherapists in our whole hospitals. So we've been trying to think of other ways to help patients rehabilitate. And one idea has been to train nurses and family members to provide rehabilitation. And we haven't got any evidence of efficacy yet, but we certainly have got a lot of positive responses from staff and patients and their family members being involved in this process. So moving on to the other aspect of supportive care is really trying to manage cardiovascular problems in an increasingly elderly population. Autonomic nervous system dysfunction, generally speaking, is our #1 cause of death in this patient group now. They're not dying of muscle spasms because we can ventilate them, but the cardiovascular complications rate is increasing, and it's very difficult to deal with, particularly when we think that these are older patients with significant comorbidity. Now, I don't expect you to kind of really fully digest this slide, but I put it up there to show how, so it's a study where you looked at catecholamines in the urine, which were a measure of autonomic output over 24 hours, and how that compared to systolic blood pressure and heart rate, or we did lots of other things, looking adrenaline and noradrenaline. We've shown previously that these are very elevated in tetanus and very strongly correlated with clinically diagnosed autonomic nervous system dysfunction. But I think you can see here is that these relationships we've shown when we look at it in a lot of detail are really non-linear. And that may simply be that's the way the cardiovascular system is controlled, and that is a feature of the autonomic nervous system dysfunction. But I think it also reminds us that there are probably other things going on in a lot of our patients. We know there's pre-existing ischemic heart disease. It's usually undiagnosed in our patient group cohort. Diabetes is common. Hypertension is incredibly common. And then there are other things we pick up more and more with our critical care facilities and monitoring, pulmonary emboli, acute ischemia, and myocarditis. We're seeing more commonly in this population. We have the ability to see some of these things. And I think, you know, as we move forward in Vietnam, working out how we can manage these and better strategies is a real priority for us, because it can be very challenging. And patients with low blood pressure, our kind of previous go-to was just to start an inotrope or a vasopressor. And I think in some of these patients, this probably isn't the right thing. So to try and understand what's happening in autonomic dysfunction is where a lot of our research at the moment is going. I put this slide in. I started making it actually for a different talk where I was trying to convey to people who are non-experts what it takes to look after some of these patients. But I know I'm in a room full of experts, but it's kind of a nice way of visualizing where we've come from. So when I started working on tetanus over 25 years ago, we didn't have a lot more for most patients than is shown. We had some simple monitoring, manually recorded, and you know, 1 or 2 clinicians around to do that. If patients became more unwell, though, and now we'd start to step up that therapy quite early on. We certainly be interested in monitoring more. We probably would starting some more blood tests. And now I've just told you that if you add all this extra stuff, you can really bring down your mortality in tetanus, and you can really save some lives. But that comes with a lot of cost in terms of the expertise and infrastructure that's needed, particularly in terms of people. And then, of course, what I've missed out is this part, and this is probably the most important part, is the bit we care about, it's the bit the patients care about too, and their families, and that's having people around to look after patients. And certainly, I think the danger at the moment is we're so focused on the technology and the results, and it's really important to remember that we've got time to be at the bedside with the patients. And it's so, you know, I've just been so happy hearing you have these amazing memories, and from what I know happens in the hospital here, how important that is to you as CMC, and that where in many countries medicine is moving away from that is very much at the heart of what you're doing. And I think in countries like Vietnam, it's genuinely a danger that people are focused on buying more equipment and more technology and moving away from the patient. So why have I put that in? I put this slide in to tell you, well, we're not going to be able to do that in Vietnam easily because we just don't have the staff. These are healthcare workers throughout the world, divided by income bracket, relatively recently published in the BMJ. And you can see that lower middle and upper middle income countries are really way behind in the amount of healthcare workers around. This map is not surprising. Where are the big gaps? Same kind of places where a lot of diseases of poverty and tetanus is occurring. So where we are now in Vietnam is we're trying to work out ways of improving outcomes at affordable cost, but at the same time capitalizing on that expertise that is available and freeing up staff perhaps to be doing the things that are most important. So I'm particularly interested in wearable monitoring at the moment. We don't have many monitors. Patients get moved around the place to fit in and provide space. And wearable monitors allow us to maybe be more flexible in the way we monitor patients, so they can stay on patients, they can move with patients, they can connect to simple devices like phones and give you all the data you need. But also, we have developed a relationship with a local company who allow us to have a nice central monitoring system, but at much lower cost. So patients can be monitored, or one nurse looking after many patients can keep an eye on several at the same time. Also, interestingly, we've decided to use devices that give us these full waveforms data. Most of the time, the devices that you use get rid of most of that data. They'll give you the summary oxygen in the blood or the summary heart rate, but they won't give you as an output that actual waveform from which they've calculated those things. Why do we want to do that? Because that waveform contains a lot of physiological information. I know you've been learning good bedside technique here. And one of the things we do in Vietnam when we're teaching particularly young doctors about dengue is we make them all go and feel the pulse, because not to measure it, but to feel it, to feel the character and feel particularly the brachial pulse, because we can feel that in edema. And that's because it contains so much extra information that we don't think about. So as a way of trying to characterize some of that information, heart rate variability has been pulled out. The beat-to-beat heart rate is closely controlled by the autonomic nervous system, balance between sympathetic and parasympathetic. So it's maybe not surprising that in tetanus, we might expect to see that dysregulated. And indeed we do. These are data from a study we did a few years ago where we measured heart rate variability in patients with severe tetanus, Ablett grade 3, and severe but with also autonomic dysfunction, Ablett grade 4. And we can see a change in that variability. In a larger study, more recently, we've shown that I think you can see, hopefully you can start to see some clear patterns between patients with just spasms, patients with a lot of spasms but are on a ventilator, which look quite similar, and then the patients with proper autonomic nervous system dysfunction. So it's quite encouraging. Why do we want to do that? Well, because we are trying to work out which patients have got proper autonomic dysfunction, which have got cardiac problems, different cardiovascular problems. And also potentially these things could be used remotely for people who are not so expert dealing with these kind of conditions. We've taken it a step further, and we're now at the stage of using AI on these. So rather than trying to work out the heart rate variability, calculating it ourselves, we are effectively being quite lazy, and we're just throwing the whole waveform into AI. I say that very flippantly, but we have some real experts in AI who we are working with, and we're analyzing these whole waveforms. And what we're seeing is that we can predict severe tetanus as well as other infectious diseases using this type of AI approach. So is this the future then? We're now moving towards, and in fact, in the next few weeks, we're going to do our first real-time test of this kind of mechanism in Vietnam. So using a wearable device that transmits data to a remote server, we run an AI model that tells us if the patient's getting better or worse, and we're going to be running back to the bedside to see, is our model right? I'd like to say, yes, it is. It's really great because I think it is interesting. But I think that would be the very, very much the wrong way to end this talk. And the way what we should be doing for tetanus, of course, is vaccinating people. So with that in mind, I'd like to say thank you so much for having me. I've really enjoyed coming. It's been a joy to meet so many of you, and I hope I get a chance to talk to more of you this evening and tomorrow. So thank you very much.
Thank you, Dr. Louise Thwaites. So as we move forward in our program, it's time to honor Dr. Louise Thwaites. To formally recognize Dr. Louise, we have a special plaque presentation accompanied by a citation. I invite Dr. Sudha Jasmine to kindly read the citation and to present the plaque.
It's my honor and privilege to read the citation in honor of the pioneering contribution in infectious diseases awarded to Dr. Louise Thwaites for unswerving commitment to furthering the practice of infectious disease in a socially relevant context in developing countries. We, the faculty of the Department of Internal Medicine and Infectious Disease at Christian Medical College, Vellore, are privileged and honored to award distinguished Dr. Louise Thwaites with the 13th Professor Benjamin M. Pulimud Oration in Tetanus, Evolution of Management Concepts for this old scourge. The Professor Benjamin M. Pulimud Endowment Oration was established in 1995 to honor an inspiring teacher, a compassionate physician, and an extraordinary human being who has influenced thousands of undergraduates and postgraduates with a strength of character, principles, and morals, apart from his legendary clinical skills. His emphasis on cost-effective care and ensuring treatment for each according to their need, whether emotional or social, has influenced the practice of internal medicine by many undergraduates, postgraduates, and peers. Christian Medical College Vellore salutes this pursuit of academic excellence in response to a vision fulfilling unmet needs of the disadvantaged communities in the tropics through innovations in education, research, and training in infectious disease by Louise Thwaites and Professor Benjamin M. Pulimud.
Thank you, Dr. Louise Thwaites, for your wonderful message. As we near the conclusion of this wonderful event, it's time to reflect on the remarkable moments we've shared and express our gratitude to everyone who made it possible.